audio course on PET and gestational hypertension. Episode 7, Medications and Regimens with Mechanisms. This episode is about drug choices, but we will not learn them as a shopping list. In hypertensive disease of pregnancy, every medication has a job. Some prevent stroke, some prevent seizure, some stabilize BP over days. Some protect the fetus from prematurity complications. Some are safe postpartum because the fetus has delivered. If you know the job, the regimen becomes easier to remember. Start with acute severe hypertension. The job is stroke prevention. Severe BP means systolic at least 160, diastolic at least 110, or both, persistent long enough to be real. The goal is not normal blood pressure. The goal is to leave the severe range without crashing uteroplacental perfusion. ACOG first-line acute options include intravenous labetalol, intravenous hydralazine, and oral immediate-release nifedipine. Labetalol blocks alpha-1 receptors and beta receptors. The alpha effect lowers vascular resistance. The beta effect blunts heart rate and contractility. ACOG dosing begins with 10 to 20 milligrams IV, then 20 to 80 milligrams every 10 to 30 minutes, up to a maximum cumulative dose of 300 milligrams, or an infusion of 1 to 2 milligrams per minute. Avoid or be cautious with labetalol in asthma, heart block, bradycardia, or decompensated cardiac disease. The mechanism explains the cautions. Beta blockade can worsen bronchospasm and bradycardia.
Hydralazine directly relaxes arteriolar smooth muscle. ACOG dosing is 5 to 10 milligrams IV or IM, then 5 to 10 milligrams every 20 to 40 minutes, up to 20 milligrams, or infusion, 0.5 to 10 milligrams per hour. It can cause headache, flushing, tachycardia, and hypotension. Nifedipine blocks L-type calcium channels in vascular smooth muscle. Immediate release nifedipine is useful when IV access is delayed or not available. ACOG dosing is 10 to 20 milligrams by mouth. Repeat in 20 minutes if needed. Then 10 to 20 milligrams every 2 to 6 hours. Maximum 180 milligrams per day. Do not use sublingual nifedipine. The Hadassah delivery room crisis protocol is similar. Labetalol 10 to 20 milligrams IV, then 20 to 80 milligrams every 20 to 30 minutes, maximum 300 milligrams. Hydralazine 5 milligrams IV or IM, then 5 to 10 milligrams every 20 to 40 minutes. Nifedipine 10 to 20 milligrams by mouth, repeat within 30 minutes if needed. Now, stable or non-urgent BP treatment.
Here, the guidelines diverge. ACOG clearly mandates urgent treatment for severe BP. NICE treats sustained BP above 140 over 90 and aims for 135 over 85 or less. ISSHP recommends treating hypertension in pregnancy regardless of the hypertensive disorder, targeting diastolic BP of 85, influenced by the CHIPS trial. SOMANS also supports antihypertensives for stable chronic hypertension, gestational hypertension, and stable non-severe preeclampsia. Hadassah local protocol does not use chronic medication for gestational hypertension and does not treat mild-range BP during labor. So the resident must know both the shared rule and the local rule. Shared rule, severe BP is urgent everywhere. Local rule, mild to moderate BP treatment depends on the guideline and department. Maintenance options include labetalol, nifedipine modified release, and methyldopa. Hadassah lists labetalol 200 to 2,400 milligrams per day, divided into 2 to 4 doses, nifedipine slow release 30 to 120 milligrams per day, and methyldopa 0.5 to 3 grams per day, divided into 2 to 3 doses. Now, magnesium sulfate. Magnesium's job is seizure prevention and seizure treatment. It is not an antihypertensive. For eclampsia, magnesium prevents recurrent seizures. For preeclampsia with severe features, it reduces the risk of eclampsia. ACOG emphasizes the MAGPIE trial, where magnesium reduced eclampsia by more than half. Regimens vary. A common regimen is a 4 to 6 gram IV loading dose, followed by 1 to 2 grams per hour. SOMANS recommends 4 grams IV loading, followed by 1 gram per hour for 24 hours total, or from the last seizure. NICE critical care guidance uses 4 grams IV over 5 to 15 minutes, then 1 gram per hour for 24 hours, with 2 to 4 grams for recurrent seizures. Hadassah uses 4 grams in 100 milliliters saline over 20 minutes, then 10 grams in 500 milliliters at 2 grams per hour. Toxicity is where pharmacology becomes bedside safety. Magnesium is renally cleared. If urine output falls or creatinine rises, magnesium accumulates. Reflex loss appears before respiratory arrest. ACOG lists therapeutic levels around 5 to 9 milligrams per deciliter, loss of deep tendon reflexes above about 9, respiratory paralysis above about 12, and cardiac arrest at much higher levels. Hadassah uses a similar practical table: therapeutic 4.8 to 8.5, loss of patellar reflex around 8.5, respiratory depression above 12. So monitor reflexes, respiratory rate, mental status, urine output, and renal function. If toxicity appears, stop magnesium and give calcium gluconate. ACOG uses 10 milliliters of 10% calcium gluconate IV over about 3 minutes. Now, corticosteroids.
Their job is neonatal, not maternal cure. If delivery before 34 weeks is likely, and the situation allows time, antenatal corticosteroids reduce neonatal respiratory distress, intraventricular hemorrhage, and other prematurity complications. A repeat course may be considered if risk persists after the initial course, according to local protocol. At 34 to 36 plus 6, late preterm steroids may be considered in selected patients, but ACOG is clear. If severe preeclampsia at or beyond 34 weeks requires delivery, do not delay delivery solely to complete steroids. Magnesium can also be used for fetal neuroprotection when early preterm delivery is imminent. That is a separate indication from maternal seizure prophylaxis. Same drug, different job. Now, postpartum medication. After delivery, there is no fetus exposed through the placenta. That changes the medication landscape. NICE and ISSHP allow breastfeeding-compatible agents, such as labetalol, nifedipine, hydralazine, and in many cases ACE inhibitors, such as enalapril or captopril. Methyldopa is often avoided postpartum when alternatives exist because of mood concerns, though data are limited. NICE recommends starting postpartum treatment if a patient not previously on medication has BP at least 150 over 100. ISSHP targets diastolic 85 postpartum, similar to antepartum.
NICE also gives practical postpartum details. Methyldopa used in pregnancy should be stopped within 2 days after birth. Enalapril can be used postpartum, but renal function and potassium should be checked. If one agent is not enough, combinations such as nifedipine and enalapril are reasonable in that framework, with labetalol or atenolol added or substituted when needed. Diuretics and angiotensin receptor blockers are generally avoided for hypertension treatment in breastfeeding women when possible. Finally, NSAIDs. This is a guideline tension medication. ACOG reviews reassuring evidence that ibuprofen and other NSAIDs do not meaningfully worsen postpartum BP and preeclampsia with severe features. ISSHP allows NSAIDs if other analgesics are ineffective and there is no acute kidney injury or risk factor for it. SOMANS is more cautious and recommends against routine NSAID use in preeclampsia until more safety data are available, while allowing short inpatient use when alternatives are inadequate. The practical rule is not never and not always. Avoid NSAIDs or monitor closely in acute kidney injury, chronic kidney disease, uncontrolled BP, sepsis, hemorrhage, or fluid overload risk. Let us close by sorting the medications by job. Labetalol, hydralazine, and nifedipine treat dangerous BP. Magnesium prevents seizures. Corticosteroids help the preterm fetus. Maintenance antihypertensives prevent severe BP recurrence. Postpartum medications protect the mother when fetal exposure is no longer the same issue.
The resident reflex is this: before choosing the drug, name the danger. Stroke, seizure, prematurity, recurrent hypertension, pulmonary edema, or postpartum vascular risk.
the right regimen is easier when the job is clear.